Good afternoon. My name is Kelli Stajduhar. I'm a professor in the School of Nursing and a research fellow at the Institute on Aging and Lifelong Health at the University of Victoria in Victoria, Canada. I want to thank you for the invitation to speak at your first annual meeting of the International Neuropalliative Care Society, and share with you some insights around or some of the work that we've been doing around equity-oriented palliative care. I'm just going to try and advance my slides here. There we go. When I said that we have a beautiful campus, we really do. We're located on the west side of Canada in the Pacific Northwest. I'm grateful really to live and work and play on the lands of the Lekwungen-speaking peoples on whose traditional territory the University of Victoria stands. I'm going to admit right off the bat that I'm not an expert in neuropalliative care, and nor will I ever claim to be. But I think the reason that I was invited to come and speak with you today is for the work that I'm doing around equity in palliative care. I had the opportunity, so for about 15 years of my career, I worked in practice as a clinical nurse specialist and nurse clinician in oncology, palliative care, and gerontology. And it was at that time that I had the wonderful opportunity to meet a man named Dennis Kay. Dennis was a man who had been diagnosed with ALS, and he was living on Quadra Island, which is quite a remote island off Vancouver Island, where I live. And he'd come into our hospital for respite care. And on a consult, I was asked to come and see Dennis because some of the staff that were working with him were really challenged in knowing how to best meet his needs. I got to know Dennis pretty well. I worked with him for quite a long time. But one of the things that I really realized at that time is that even though I had quite a bit of experience in palliative care, what I'd learned about palliative care, while applicable in some ways, didn't quite equip myself or my team to be able to care for Dennis in the ways that he needed to be cared for. I grew up at a time when palliative care started primarily within the cancer care system, and it was that, I seem to be, anyway, it was during that time that that I learned everything that I was learning about palliative care was from the care of people with cancer. And it was my experience with Dennis really that really made me stop and think that, boy, there's got to be a lot more people out there who are dying who don't have cancer, but they could maybe benefit from a palliative approach to care. And so I began thinking about these questions. Who has palliative care been most designed to serve? Who has palliative care been least designed to serve? And are the models of palliative care that we have in play today the best models to achieve equitable access to care for all people who are dying? I began thinking about what could an equity orientation more broadly bring to the practice of palliative care, and what might that look like? And thus began a kind of a research program focused on equity-oriented palliative care. From 2011 to 2018, I led a big provincial nursing health services research initiative focused on the integration of palliative approaches to care across sectors of the healthcare system. What we were really, where this project came from was the idea that while we have really good palliative care services in our province, it is the case that most people that access palliative care are people with cancer. And we were starting to think about, well, what about people who had neurologic conditions? What about people who had other chronic illnesses like COPD or heart failure or kidney failure? And I know this isn't rocket science. Joanne Lynn showed us many years ago the varying trajectories that occur for people who are dying. And we could think about those trajectories of decline. But actually, how do we integrate these principles of palliative care into the care of people with advancing and life-limiting chronic illness? And that's what this initiative was trying to do. We were really trying to identify, and we did this through a very large knowledge synthesis, the kind of intersection between principles of palliative care and chronic life-limiting illness. That what could we learn from palliative care that could be brought in to our work with people who had chronic illness in ways that would be helpful for them. And in fact, we really wanted to delineate some of these key characteristics of what we came to call a palliative approach to care that could be found in the empiric literature, so that we could contribute to conceptual clarity on a palliative approach to care. That is, maybe thinking about how we could adapt principles from palliative care earlier on in the illness trajectories of people with chronic illness, to adapt that knowledge that we had learned from palliative care into the care of people with chronic illness, and then how it is that we would integrate that knowledge into everyday care, kind of under the belief that people, wherever it is that they happen to be within the healthcare system, have a right to have access to and to benefit from the principles of palliative care. And this really stemmed from a place of or a belief that we all have a right to dignity and life and death, and that it's our job as health professionals to be able to bring this to others. So we really started to think about framing our work around equity, and how an equity-oriented lens could help shape the way in which we thought about palliative care for various populations who could benefit from palliative approaches to care. And here, I guess what I want to say is I'm not talking necessarily about how do specialists from palliative care actually leap in and provide care to people with ALS or provide care to people with liver disease, but more along the lines of how do we integrate those principles of palliative care into systems of care that already exist. And I mean, it's one of the reasons why when I heard about the development of the International Neuropalliative Care Society, I thought this is wonderful, because it is really the intersection of these principles of palliative care with various disease groupings that will really help us in enhancing that capacity to engage in equity-oriented care at the end of life. So I really began thinking about equity as an orienting lens for the work that we're doing in palliative care. So I'm going to talk a little bit about some of the premises of health equity, just to provide a little bit of scaffolding for the work that I'm going to talk about, that I'm engaged with at the moment. So, you know, I think the concept of equity has been around for a very, very long time, and health equity and achieving health equity has become increasingly commonplace in health systems, particularly over the last decade or so. I think many, many health systems now have equity statements in their mission statements and in their vision statements, and we all want to achieve equity. But what does that really mean? And what can we actually learn from fields such as legal studies and philosophy and sociology and critical race theory and post-colonialism to help us think through how it is that we create more equitable health care systems for an aging society? So health equity really is considered to be society's obligation to improve unequal health outcomes in our populations. The kind of idea of equity is really bringing us to focus on the justice and injustices, how justice and injustices are sustained through our institutions, and to highlight how really individual experiences are nested within a much larger political, economic, cultural, and social context. So we see if we look at that person in the middle of this diagram as nested in a larger community and then a larger system, we begin to see how these systems and communities can perpetuate inequities when certain things are not addressed. So health inequity really refers to those differences in health outcomes and access to health services that are things that are unnecessary and avoidable, and therefore unjust and unfair. So if we take actions on the systemic causes of ill health and help to address those wider social determinants of health, it is our way through to addressing the inequities that exist and that make a difference to the overall health outcomes of the people that we serve. This is a diagram from Canada, but I don't think that it probably differs all that much, at least in the global north, that the kinds of things that tend to make people sick focus much more on what we would call the social determinants of health, those things like income, race, gender, education, than our biology or our environment, for example. So these things like income and education and gender and race and housing, for example, when those kinds of needs are not met, they are the kinds of things that put people at much greater risk for negative health outcomes. And that is the case as well, and even within palliative care. So health equity asks society, via the institutions that we work in, to take action against inequities that exist. And I guess what I would say here is that there are many different forms of inequities, whether it's by race, ethnicity, gender, sexual orientation, your access to housing, your disability status, how much money you make. These are the kinds of things that create inequities in a population, and these are just the kinds of inequities that lead to poorer health outcomes in life, but also to poorer outcomes when people are at the end of life. So in relation to health, equity-oriented approaches call on institutions to, number one, direct attention to the social determinants of health, those kind of material and non-material conditions that result in differential risk and suffering. Equity-oriented approaches to care call on our institutions, our health institutions, to emphasize intersectoral approaches to prioritize the health for those who experience the most vulnerability. And that means thinking about how we direct resources to those with the greatest needs. In relation to health, equity-oriented approaches aim to recognize and reduce the effects of structural inequities like poverty, sexism, racism, on people's access to and receipt of health care and access to the social determinants of health. Equity-oriented approaches to care aim to recognize and reduce the impacts of multiple intersecting forms of racism, discrimination, and stigma, and to address the frequent mismatches between usual approaches to care and the needs of people most affected by health and social inequities. So in a sense, what health equity is asking us to do is to look at people within the context in which they live, and how the social determinants of health and the ways in which our system is organized and functions act to actually create inequities for people in their access to health services and in their access to better quality of life. Equity-informed approaches also are compelling us to ensure that there's representation of those most directly involved with the inequity by working both from the top up and from the bottom up and from the top down. So bringing together people who make decisions in our systems in participatory ways with communities, so that we can affect solutions that are going to work for people. So that was just a sort of a little primer on equity to kind of structure some of what I'm going to talk about in terms of what equity-informed approaches to palliative care might look like and mean. So in 2016, we wrote a paper called Death is a Social Justice Issue, Perspectives on Equity-Informed Palliative Care. And we were really making the argument that most definitions of palliative care don't really make explicit the additional attention needed to address social and structural inequities that profoundly shape health, illness, and dying experiences for people who are made particularly vulnerable by a constellation of socio-political, economic, cultural, and historical forces. And I guess what I would say is that traditionally in palliative care, while we think about palliative care as whole person care and paying attention to all of the things that affect people, it seems to me more and more that that whole person notion of palliative care gets usurped by other things that are seemingly more important. So an equity-informed or an equity orientation to palliative care, thinking about equity, gives us a lens to look at who current palliative care programs or services are working for and serving, and who they are not. Are we directing our attention and resources to those with the greatest needs? Do our palliative care services and philosophies pay explicit attention to equity? And within the context of our health services and our palliative care services, are we working in intersectoral ways to allow for more equitable care for people who face inequities? We know that there are disparities in access to palliative care, and they emerge partly as a result of some of our own deep-seated assumptions with regard to who is in need of such services. If you look at the data across most of the developed world, a large majority of people who currently access palliative care have particular socio-demographic and economic profiles. Most research will show us that the large majority of people in the global north who access palliative care or get access to some form of services related to a palliative approach to care are either those who are diagnosed with cancer, from majority cultural and religious groups with strong family and community connections, and who live in stable housing. But those who are in need of palliative care are not composed of one homogeneous population group. And I think for the work that you are doing, I think that comes into play because what you're trying to do is enact the integration of palliative care principles into a group of, or a population group who has historically maybe not been served best as they are coming to the end of their lives. People who are dying are situated within a web of intersecting social, economic, cultural, political, historical, geographic, and physical contexts. And this is really going to dramatically shape their needs for palliative care, the types of services and supports that they require, and ultimately their access to these kinds of supports and services. And so I've been moving forward a program of research that really is trying to think through how can health and social care, so those connections, that intersectoral approach to larger community, how can health and social care ensure equitable approaches to palliative care, taking into account intersecting vulnerabilities and inequities? How can we intervene early enough to promote physical, emotional, social, and spiritual well-being so that people who are dying and their chosen family can live the best quality of life up until the time they die? How can we prioritize what matters most as people are coming to the end of life? And how can we capitalize on the assets in our community and within our citizens to support equity-oriented palliative approaches to care that allow people to live in community if they wish as they are dying? So the particular population of people that I work with are people who face inequities like homelessness, poverty, stigma, and who also have chronic health conditions such as lung, liver, kidney disease, cancers, and neurologic diseases. And we're really looking at the intersection then of what we call structural vulnerabilities and chronic life-limiting illness, because we know that when people have certain chronic life-limiting illnesses and also live and experience things like homelessness, living in poverty, have been criminalized as a result of various factors, or experience racism or stigma, they are at severe disadvantage when their health declines. This is a quote from a Canadian reference, but I don't think that it would be different anywhere else. We've known for a very long time that health inequities exist. These inequities affect all Canadians and others, but they have especially strong impacts upon the health of those living in poverty. Adding social science evidence, that is understanding the social structures and power relationships that exist in our society, we've now accumulated indisputable evidence that social injustice is killing people on a grand scale. So our research is really trying to address those systemic and social inequities that are faced by populations of people who are positioned as structurally vulnerable, and of which some are those who experience neurological disorders. Some of the research that we've done already has really shown us that people who are on a palliative trajectory and who experience structural vulnerability have many, many unmet needs. Typically, they lack trust in the healthcare system and its providers, even if they are palliative care providers. And many feel judged as a result of provider bias about mental health issues, substance use issues, because they live in poverty, because they're racialized, because they have disabilities. So, you know, these social and these systemic and social inequities can really, really lead to people not wanting to access our services because of lack of trust in the healthcare system and its providers itself, because they feel judged when they're seeking care, and that means that they have multiple unmet health needs even when they're at the end of life. So I'm going to read to you a little excerpt from a report that I don't think it's in this report, but it is an excerpt from this study that we released in 2018, looking at access to care for people at the end of life who also experience inequities and structural vulnerabilities, just to kind of situate this in a kind of a solid example, what I mean, and what happens for folks. And although Leslie, who I'm going to be talking about, had a diagnosis of cancer, You could well insert this example into anybody with a neurological issue who is also facing structural inequities. So Leslie was a 53-year-old Indigenous woman and residential school survivor. Canada's colonialist policies of placing Indigenous children into residential schools inflicted immediate trauma. It denied her of education as a child, and it disrupted her family relations through dispossession, separation, and displacement. This structural violence carried forward into her adult life. This is, by the way, Leslie was a participant in one of our research stories, so the story that I'm telling you is a true story. Her elementary school level education and relatively low cognitive functioning made it really difficult for her to understand the ramifications of her cancer diagnosis. Despite having a large family in her home community, she was estranged from them geographically and socially, largely as a function of poverty. Her boyfriend and niece were her main support people. Once she was diagnosed with cancer, Leslie moved from her single-room occupancy hotel into a supported housing facility where she was connected to housing workers, home care services, and a meal program for food. These services buffered to some extent her structural vulnerability, but at the same time the agency's policies were not particularly responsive to her social situation. Leslie's boyfriend rarely spent time with her at her home because of his mobility issues and the housing facility's no smoking and drinking policies. As a result, Leslie would take public transit to visit him every day, and during these trips she experienced multiple falls that left her with broken ribs and a fractured hip. While Leslie told us that seeing her boyfriend was really important because it distracted her from the pain that she was experiencing, because they played lots of board games together. He had a cat, so they spent time with the cat. She helped him clean his house when she was able to do that. Her housing and care workers were increasingly concerned about her fall risk and her vulnerability to medication theft, as she was on opioids for pain management. And her boyfriend also was a user of opioids. As Leslie's health continued to decline, her boyfriend moved into her housing unit to provide her with full-time care. However, he was later evicted and temporarily banned from coming into the housing facility because he had violated the facility's no drinking policies. The abstinence-based policies prevented him from visiting her regularly, and so prior to Leslie's death, they saw less and less of each other. Leslie was deeply lonely, despite the presence of various paid support people. And in the final month of her life, she accessed ambulance and emergency care multiple times. And though connected to palliative care services, there was talk a week prior to her death about deregistering her because her cancer was not progressing fast enough. Leslie died in her supported housing facility one day after leaving respite care. At the moment of her death, Leslie had a housing worker by her side. Although multiple streams of social and structural inequities coalesced to shape Leslie's experiences, her story amplifies how the oppressive forces of colonialism and racism shaped her life opportunities, her choices, her decisions, and eventually her premature death. The structural violence that she experienced throughout her life affected not only her sense of self-worth, but also her familial connections and social networks, her mental capacity and educational attainment, her ability to acquire and maintain paid employment, her access to income, material resources, and housing, and if and how she could voice her needs to her formal care providers as she approached the end of her life. While some of the supports that were in place mediated to some extent her structural vulnerability, abstinence-based policies, mobility, and transportation challenges, along with ableism and living in poverty, prevented her from being with her chosen support person in her final days of life. So these are the experiences that we repeatedly hear in the context of the work that we do in equity-oriented palliative care. And I wanted to provide that example as a way to kind of solidly demonstrate how these intersections of inequities and vulnerabilities coalesce together to make end-of-life care really challenging for people who are at the end of life and also face inequities. So we have here in Victoria, where I live, we have a research program called Equity and Palliative Approaches to Care, which is a fairly large community collaborative informed by a research program that's being led by me out of the University of Victoria. And our aim really is to work together in that intersectoral collaborative way to conduct research locally, nationally, and with international partners, really to develop resources and tools and programs and services aimed at improving access to quality care for people facing the end of life and who also face inequities like homelessness, poverty, isolation, racism, and stigma. We have what we call an inner city action team. This is a team of people who work in inner city contexts. That's the context that a lot of our work is happening in right now. And that inner city action team is really made up of a group of people who are really trying to build kind of that relational bridge between siloed systems of care that exist for people who are at the end of life and also experience inequity. So we have a large local intersectoral collaboration going on between inner city service providers, so housing workers, harm reduction workers, people who are in decision-making positions, and people who make policies provincially for end-of-life care. We work very closely with people with lived expertise of inequities and their chosen supporters. And I'm going to tell you a bit about PORT in a minute, but this is just all to say that really what we're trying to do here is bring together the various sectors that are at play when we're trying to care for people who face inequities at the end of life. So we work with housing providers, social service providers, healthcare providers, bringing them all together in a kind of collective collaborative to be able to enable better care in our community. So we have, in our collaborative, we have a number of research projects that are ongoing. I'll just mention a few in a minute. We have pretty extensive community partnerships. We are working in Canada primarily with folks in British Columbia, in Alberta, and Ontario, because that's where a lot of our equity in palliative care work is going on. And we've started to establish some collaborations with people in the US, Australia, the UK, New Zealand, Belgium, and Sweden. Just people are very interested in this work. And I'm also leading a large pan-Canadian community of practice. So bringing clinicians, people who work in palliative care, people who work in inner city community-based organizations, healthcare administrators, social service administrators coming together in a community of practice where we're trying to move forward these ideas of an equity lens within the care of people who are dying. So we are just going to be launching a study, for example, on family caregiving in the context of structural vulnerability at the end of life. So we know from the research that we do that there are various family forms. There's street family, there's chosen family, there's friends. There are biolegal family members, but more often than not, those family members are quite estranged. So who are caregivers for these folks who are experiencing vulnerabilities? I'll talk about, we have a project that we're almost ready to go on around advanced care planning in inner city communities, and I'll tell you about that in a minute. Right now we're collecting data. We know that inner city workers, housing and harm reduction workers, for example, play a big role in support of people who are at the end of life and who also experience inequities. But they also kind of sit in this dual role of care provider and like service provider and family. They're de facto family in the absence of family. So, and experience pretty deep grief, loss, and trauma because their organizations are not necessarily set up for the integration of palliative care. And we're beginning discussions now with small city and rural communities to address issues related to people who are dying in those communities who may not have as much access to services as people living in larger communities. So just an example of how this kind of collaboration works. So this is, in this picture is myself and a woman named Paige Phillips. Paige is a harm reduction worker in downtown Victoria. She works for a drug user organization. Aside from the number of people who are dying from the toxic drug supply and the opioid epidemic, there are a number of people, of course, in the populations that we work with that have multiple coexisting comorbidities that really put them at high risk of death. One of the things that happens in this community is, you know, if people get really sick, they go into hospital, sometimes with infections, sometimes with advanced cancers, or other advanced COPD or heart failure, or other diseases. You know, there's been no advanced care planning done. And one day, Paige was in one of our action team meetings and was crying and was talking about the story of a gentleman that she had just been supporting in the hospital who was dying, and he had died, and he had a number of things, including this Detroit Red Wings jersey that he had been wanting to give to people in his community. And those things got thrown in the garbage after he died because he didn't have a family member documented on the chart. So, you know, Paige was very, very upset because death really is upsetting in these communities, even though it happens very frequently. And I said to Paige, you know, in palliative care, we would normally do something called advanced care planning. And I explained that to her, and Paige went, oh my God, and she went home and she went to the government website and downloaded the advanced care planning document and went, wow, this is 56 pages. And she came back to our action team meeting the next time. We meet every 2 weeks for 2 hours. And she had whittled down that 56 or 52 page document to 6 pages. And we worked together as a team to actually create an advanced care planning document that would work in the community, which is being taken up by the hospital social workers and is now kind of a point of practice for us in Victoria and in other cities in Canada. So that's one example of how you can create things when you're working in collaboration with community that work for them and that they find relevant. And so now we have housing and harm reduction workers who are out in the community doing advanced care planning with people who experience inequities. One of the things that we have been able to do with our research is we now have 3 mobile palliative care programs in Canada that focus their care on people in inner city communities who experience inequities. The Peach program in Toronto, which was established quite a few years ago now, but informed and its expansion informed by some of the research coming out of our research program, the CAMP program in Calgary, Alberta, and the one that I've been most involved with is the Palliative Outreach Resource Team here in Victoria. So in some ways people might look at this and they might say, okay, now we've got like this specialized palliative care team that's just going in and taking over care, but it's not how the model is built, because we know that for people who are living in our communities and face inequities, they intersect with many care providers. And so our Palliative Outreach Resource Team is a mobile team. Katie is the nurse you see there with her bike. She goes around on her bike around the city of Victoria helping people who are in need of palliative care. Our approach really is to work toward building our community's capacity to deliver equitable care in ways that we can, so that we kind of not only think about how it is that we develop our health services to provide better quality care for people at the end of life, but how we actually work in and with community to do that in a way that's workable. So for example, to be able to get services from our port nurse, our port physician, we have an open referral process. So any housing worker, harm reduction worker, family member can refer to the port program. So we really try to keep things very flexible, very open, because that's the way that one has to work in these communities, to be responsive to communities. And so I would say equity is all about being and delivering or developing equity-oriented services is highly about flexibility. If you want to address equity, you need to provide the space for people coming together within communities that are most affected by the inequities. Otherwise, it's really difficult to get outside of our disease silos, our health service models, and our increasingly biomedical perspectives that don't really allow us to fully and deeply understand how the social determinants of health can affect the populations that we serve when they're at the end of life. And so just a few concluding slides. You know, we may not, in our work with people who are dying, have the ability to affect the multiple determinants of health, and we may not be able to erase the harm of inequities on people's health and quality of life. But we can address health inequities directly during our clinical encounters or our design of our palliative care programs and services. We can develop structural competency, which really is allowing ourselves or developing in ourselves an awareness of how social, political, and economic structures influence our interactions with the patients that we serve. We can personally and explicitly commit to equity. We can develop supportive organizational structures and policies and processes that really advance an equity-oriented approach to care for people who are dying. We can attend to the power differentials in our work. We can tailor programs, care, and services to the context in which we live, because what is going to work here in Victoria might not actually work for you in Boston, for example. We can actively counter racism and discrimination when we see it. We can work to enhance access to the social determinants of health. I always say to people that in the populations that I work with, getting people access to the social determinants of health is a palliative care intervention. And lastly, we can work together with our patients, our families, and our communities to enact care that is inequitable and that takes into consideration the unique needs for people who face inequities while they're at the end of their life. And just a thank you. And I have some contact information here. I'm really happy to have anybody contact me about the work that we're doing and thinking through how we might advance equity-oriented approaches in the context of neuropalliative care. So thank you so much.